Hi, this is Pete Miliaris of VCU Health, and in this video we're going to discuss central venous catheter insertion in the internal jugular vein. While the concept of technical steps for most central venous catheter insertions are the same, they do differ on target vessel and catheter type utilized. Before proceeding, we'd like to think through the indications of this procedure. Inadequate peripheral access can certainly be an indication, as well as the need for peripherally incompatible infusions such as TPN, vasopressors, and chemotherapies, hemodynamic monitoring, venous interventions and device placement, and extracorporeal therapy such as hemodialysis and plasmapheresis. As we think through the procedure, adverse outcomes are certainly on our mind. Catheter-associated venous thrombosis has a variable incidence in the literature. Infection risks, hematoma, arterial sticks, hemothorax, pneumothorax, pain, arrhythmias, and air embolisms. The 5 key elements of informed consent are explaining the diagnosis and the indication for the proposed intervention, a description of this intervention, the possible risks and benefits of the proposed intervention, possible alternatives and associated risks and benefits of alternatives, and then possible risks and benefits of not receiving proposed intervention. We are going to be focusing on triple lumen catheter in this video, but it's good to know the variety of catheters that exist, and certainly at your institution. Here you can see we have a single lumen catheter, which we infrequently use as we typically have a need for multiple infusions, therefore typically pursue a triple lumen catheter. Quad lumen catheters also exist. A cordless catheter is more seldomly used and mainly used for a mass transfusion protocol, given its large bore character. Sorensen is typically used for dialysis and for plasma exchange. However, we typically will place trialysis at our institution to gain the additional access point. As we're about to kind of think through our procedure, checklists of different formats may exist for different institutions. Our checklist can be seen here, has a pre-procedural component, where we're going to be reviewing the patient's chart to understand what medications they may be on that may affect our procedure, certainly antiplatelets, anticoagulants, knowing their baseline platelet levels, their coagulopathy issues, and of course imaging and prior procedure notes will be very helpful. We'll proceed with our informed consent, going through the 5 components of that as we discussed earlier. And then we'll certainly start to position ourselves. Ultimately, we'll talk about that later, utilizing universal precautions, and then doing our timeout and proceeding with the procedure details that will follow subsequently, followed by cleaning up of our environment, verifying placement, and then communicating verbally and written documentation. Now, as we're optimizing the environment, we're trying to essentially make space at the head of the bed for us to operate. So we'll shift the bed off the wall, assure the bed is locked into position. We'll remove the headboard. We're going to desire to have the patient shift up as close to us as possible. And sometimes this can be challenging with a particular bed utilized. We're going to want to make sure our ultrasound is within view, typically like it from if I'm doing a right IG approach on the opposite side of the bed. Thinking ahead a little bit, we're going to place a chucks underneath the patient just to make for easier cleanup at the end of the procedure. At this point, our patient is positioned well, but we would like to do some Trendelenburg. This will help optimize our imaging. Certainly going to want to have the head of the bed at the appropriate elevation for the operator. The Trendelenburg will also assist with reducing the risk of air embolism. We're next going to proceed to our ultrasound evaluation. Using a linear probe, going to assess the patency and direction of our internal jugular and corresponding carotid artery. We're essentially going to evaluate from the clavicle up to the jawline with gentle compression throughout to assure that patency exists. We're going to be evaluating for the vessel being, the IJ being lateral to our carotid. Evaluate, if we can, the carotid feeding into our subclavian artery. And once we have a good understanding of that, looking at the symmetry of the alternative side, it will be important as well. Now, before we proceed any further, we'll do our timeout, where we confirm the name of our patient, the date of birth, the procedure we're doing, the laterality, and the allergies of any potential medications that we might be giving. As we set up our equipment, obviously every institution may have a slightly different kind of kit that you'll be utilizing, but fairly standard across those institutions. In this case, we're drawing up our lidocaine. Sometimes that comes with a cracked vial, sometimes that comes with a rubber top. Here we're injecting some air and pulling back about 3 to 5 cc's, which should be adequate for an internal jugular approach. You may need a little additional for more subcu to traverse for ephemeral line, for example. We're going to grab our triple lumen catheter. In this case, we have a 7 French 20 centimeter catheter. We're going to place our lure lock caps on the catheter. And you can see here I'm doing all 3 of those. We're going to flush those with saline, starting with our lateral ports. And we'll flush those, and they take less than a cc each. And we'll finish with our central port, our distal port here. Flush that, and at the completion of this, we'll actually take the lure lock off with the syringe so that it is ready for once the line is in place. Going to evaluate our wire. Going to draw that back, and it's good to know the nuances of the markings on the wire. They're marked every 10 centimeter traditionally. Have that within reach. At this point, we're going to use our finder needle here. Ensure that the syringe is loose, that our needle is securely attached to our syringe. Assure that we have all the rest of our components within reach of our dilator and our scalpel. And then we're ready to proceed to setting our patient up. Traditionally, we're going to be using chlorhexidine to sterilize the field. We want to spend at least 30 seconds to 1 minute per chlorhexidine wipe and clean off a fairly large area. If the patient has any facial hair, discuss with the patient the ability, if able, to have that hair trimmed to allow for a more sterile procedure and also for better adherence of your tegaderm at the end of the procedure. And at this point, we'll grab our drape, which has some instructions to help guide us. It is a little bit cumbersome in a large drape, and you want to be thoughtful about how you're placing this. We want to ensure that it's perfectly parallel to our patient and the bed, more specifically. We have our site marked. Essentially follow the arrows on our draping. And as we're proceeding here, we're going to pull the rest to the foot of the bed to get full coverage of our patient. Typically, we'll have an assistant to help with some of this, but certainly something you can do independently. Just try to maintain sterility throughout. Now at this point, we want to make sure that we are over the appropriate site. That's why we clean off a large area. You can see here I'm not making contact with the skin yet. I'm going to sterilize one additional time, and while this takes its 2 to 3 minutes to dry, that'll give me opportunities to get more of my kit set up as needed and get my probe cover set up. Now, something not seen in this video is the monitor to my right, which is facing me so I can see if there are any alerts pop up. I have a good understanding of the basic rhythm seen on the screen in case there's any deviation from that rhythm as I proceed through the procedure. At this point, I'm going to get my probe cover, and you can see here I have my probe pre-gelled. Certainly you can use the sterile gel in your probe cover, or you could have someone pre-gel your ultrasound and hand this to you. In this case, I'm working independently, so I'm grabbing that probe cover to set that up. And they have different instructions. Getting familiar with your individual type of probe cover is helpful. You can see here I'll sterilely grab that probe, Careful not to drag that across our field before getting that sheath over completely. And we want to make sure we have good contact with that probe and with the gel to the probe cover and the probe itself, excuse me. And now we're ready to proceed with evaluating our site to assure that we have our drape in an appropriate fashion to allow us to have access to the vessel, but also allow for visualization of the wire after insertion. So here we can see a good orientation of our internal jugular lateral to our carotid. We have our site marked. We're going to use some lidocaine here, using the ultrasound to get a sense of center. Drop that probe, nice lateral approach here, notify the patient of a potential stick here and some burning. We'll see that wheel expand out. We'll let that sit for about 15 to 20 seconds or so. You'll see here I'm making an additional wheel where I anticipate the suture to be for the catheter, and I'm going to use that wheel to make a secondary wheel across to where the other suture site will be. Being careful not to inject without drawing back, as the EJ here is very superficial. We'd like not to inject lidocaine systemically. Now we'd also like to numb deep. You can see here on the ultrasound our vessel is less than 1 centimeter deep, so we can stay with our shorter anesthetic needle, but there is a longer needle if needed for deeper vessels, especially in the femoral. And we can track accordingly down to our vessel, leave about a cc or two behind depending on the depth. And at this point, while that's numbing, we'll grab our finer needle, bevel up at a 45 degrees angle. Sometimes you might need to drop the probe to provide a little bit of back tension to pierce through the skin. But in this case, we have puncture there, and we'll track that into the vessel. And you can see the dot there in the vessel for center. We'll have good contact with the shaft to the patient's skin, and recheck our flow here. Grab our wire to start threading. And we're looking at our markings here. They can indicate to us if we have difficulty traversing certain numbers of where that challenge may be to circumnavigate that. And in this case, we'll have some gauze nearby for any particular bleeding. And we're verifying our wire in the transverse view initially in plane, out of plane, excuse me, and then we're switching to an in-plane longitudinal view, and you can see the wire there comfortably resting on the bottom of our internal jugular vein. We're going to make a nick with our scalpel and think thoughtfully about how large of a nick we need in order for our catheter to penetrate the skin. You may have a little bit of additional capillary bleeding at this point, so having some gauze handy can be helpful. Now we have our dilator. This is a single stage dilation given the gauge of the catheter is smaller. And with some force, slight rotation at times can be helpful. We'll go about halfway. We know the proper depth. We're essentially trying to dilate skin, muscle, fat, and get down to the vessel, through the vessel wall. Kind of using our hand to hold the gauze there to prevent any excess bleeding. We'll have our catheter that's been set up earlier. In this instance, we're going to feed the catheter through to the end, so we have never let go of our wire in this stage. And once we have a grasp of our wire, we'll start threading our catheter over our wire to the appropriate depth desired. And then once we've achieved that depth, we'll take wire out and say wire out. We'll grab our pre-flushed lower lock here. We'll draw some blood back in the syringe, flush that through. We'll grab a fresh syringe typically to draw back some blood in the tubing to assure patency and functionality of the other side ports. And at this point, we're ready to suture down our catheter. So we'll grab our suture. And there are different techniques that can be utilized. I'll carefully make So carefully get a good enough bite to get so the catheter is not easily removed from an altered patient, being very careful not to puncture our gloves. And then after we have our sutures in place, we'll remove our drape very carefully. We'll grab some fresh chlorhexidine, non-tinted typically, to re-sterilize and clean off our area. While that's drying, we may be able to tend to some of our sharps and dispose of those, but upon dry time of our chlorhexidine, we'll take our chlorhexidine impregnated tegaderm and place that over our site to assure that the insertion site is in the center of that chlorhexidine gel. There's little nuances to get these catheters and their tegaderms positioned to be less annoying to patients. But upon completion of our tegaderm placement, and then take care of our sharps, reposition our patient. We'll order our level 1 chest x-ray while we're documenting our note. We'll review our chest x-ray for potential complications and for appropriate placement of our central line. In this case, since there's an internal jugular approach, we would like to have the catheter at the cavioatrial junction.